My name's Zoe Harper and I'm the chair of the National Pain Group at the Australian Physiotherapy Association. Today I'm joined by Annina Schmid, who's one of the international keynote speakers at the Australian Pain Society Conference. Annina is a Professor of Pain Neurosciences and Specialist Musculoskeletal Physiotherapist at the Nuffield Department of Clinical Neurosciences at Oxford University in the UK. Today we're going to be talking about neuropathic pain.
Yes,
thank you for joining us.
My favourite topic.
So Annina, can you tell us a little bit about entrapment neuropathies?
Yes, I mean entrapment neuropathies are conditions where nerves in the body are compressed as they travel through narrow anatomical spaces, and clinicians will know these conditions such as carpal tunnel syndrome, ulnar neuropathy, cervical and lumbar radiculopathy, Morton's neuroma, thoracic outlet syndrome. These are all summarised under the big umbrella term of entrapment neuropathies.
So what's kind of the prevalence of these conditions?
It's actually really, really high. So we know about 213 million people a year are newly diagnosed with an entrapment neuropathy each year. I was actually calculating that, and it's about the size of Brazil every year. And in terms of lifetime prevalence, is very common. So amongst 3 of us, 1 person will get it once in their lifetime, any kind of entrapment neuropathy. So it's very common.
So what's then the prognosis like for someone who's diagnosed with an entrapment neuropathy?
Yeah, this can be quite diverse. So some people have an entrapment neuropathy and it gets better. So that's about 50% of people who develop a carpal tunnel syndrome. But it's quite a high prevalence of chronic pain in patients with entrapment neuropathy. So for example, if people have spine-related limb pain that comes from, for example, an irritated nerve root, we know it's about 30% of people who develop chronic pain.
Yeah, so very high proportions.
Very high.
So what are the mechanisms involved in relation to pain with these kinds of neuropathies?
Yes, there's a lot of different mechanisms happening locally at the nerve site. So that ranges from microvascular changes to fibrotic changes inside the nerve, changes in axonal transport, but also structural changes to the nerve. For example, demyelination, axon degeneration, and quite a lot of inflammation as well inside the nerves. And then there's obviously, these are the local mechanisms, and then we know there's quite a lot happening more remotely. For example, inflammation can also affect areas away from the lesion site.
What might we see then in a person who's got more of that widespread neuroinflammation as a result of a very specific peripheral neuropathy?
We believe one of the things, and that has also come out in our research, is probably this widespreadness of symptoms. So for example, we know that technically a patient with carpal tunnel syndrome should have symptoms in the first 3 and half of the 4th digit. That's the classical innervation territory of that affected median nerve. But we know about 70% of people will have symptoms that go beyond that classical distribution. Or similar things in patients with a lumbar radicular pain, radiculopathy. They might have an L5 radiculopathy with radicular pain, but in fact their symptoms spread well beyond that L5 dermatome. And we believe that could have to do with this inflammation at remote sites, for example at the level of the dorsal ganglia, sensitizing other neurons that come from other dermatomes into that same area.
Do you think that can sometimes make the diagnosis of neuropathic pain challenging, particularly more in that chronic pain state, when we think about nociplastic pain often presenting with that spreading pattern as well?
I think that is exactly a danger, that we rely heavily on, for example, these dermatomes. But in fact, 2/3 of the people do not have a dermatomal distribution of symptoms. And the classical widespreadness of symptoms is often attributed to these more nociplastic type of chronic conditions. But neuropathic pain very often doesn't exactly follow these distributions. And so I absolutely agree with you. This can make it challenging. And so we should not just rely only on distribution of symptoms. But we should also, for example, investigate whether there is neuronal changes. So this can be done through a neurological examination, which would be positive, for example, in somebody with a true nerve injury. So for example, we would find muscle weakness or reflex deficits, sensory changes, which shouldn't be there in a true nociplastic condition. It's true sometimes people can have sensory changes, but often they are not reproducible. So they might be here today, on Tuesday they are here in the arm, and the next day they might be in the leg, and so they can jump around. Or let's say the pinprick abnormality is not in the same place as a light touch abnormality, so the puzzle doesn't fit. Mm-hmm. But with a true neuropathic condition, the neurological change is very reproducible over time.
So how do you think the presence of that systemic or local neuroinflammation might impact on physio practice? Are there any things we need to look out for? And then are there any things that we can incorporate in our treatment to try and address that?
Yeah, this is very interesting. We don't know as yet is the short answer. There is no research that has looked into that because it's still relatively novel, this kind of knowledge coming out. But hypothetically, I would say if we still have a nerve that is irritated and keeps being irritated, very often we should decompress in the big sense. So I'm not just talking about surgical decompression, but in physiotherapy we have a lot of options to decompress a nerve. So that could be positional adaptations, that could be certain movements that give more space, that could be trying to reduce the swelling of a nerve to again give the nerve more space. So these kind of options, I think, if we think the nerve problem is ongoing and the compression is still a feature, we should treat that very locally. But we also know that quite general exercise, so for example aerobic exercise is well known to modulate inflammation not only locally but systemically as well. And this evidence comes mainly from animal models. Unfortunately, in entrapment neuropathies, we don't have a lot of evidence as yet for example, aerobic exercise. But the animal literature is very convincing that, you know, rats that exercise, that run in the wheel, for example, or swim, they modulate their inflammation quite massively.
And then do you think there's a role, say someone's got a really irritated Morton's neuroma and they have difficulty weight bearing, they have difficulty walking and engaging in that type of exercise, is there then a role for upper body exercise to provide that neuroinflammatory modulating effect?
I would absolutely say, or even systemic exercise like aerobic. Not that we have the evidence in Morton's neuroma specifically as yet, because obviously our treatments have very much focused so far on foot and foot changes, steroid injections and all these kind of things. But I would say from especially the neurobiology, it would make a lot of sense to think a bit further away. And you probably know in the manual therapy kind of field, this theory that you could treat a spine if somebody has a distal problem has been floating around empirically for a long time. And in fact, these changes more remotely might well be one of the explanation mechanisms why sometimes treating the spine might help even if a patient has a foot problem. Yeah.
So what are the key things that physios should be assessing when we're seeing people with entrapment neuropathy?
So the main thing I believe is to look at whether people have neuropathic pain, because not everyone with an entrapment neuropathy has neuropathic pain. That sounds a bit paradox, because obviously entrapment neuropathy by definition has something to do with the nerve. But quite a large proportion of people with an entrapment neuropathy have just, I say, somatic pain. So true neuropathic pain depends from condition to condition, but it's probably between 30 and 50% of people. So it's not everyone. If somebody has neuropathic pain, we believe they need slightly different interventions, already in terms of helping people to make sense of what a neuropathic pain is, because it's so different. It can be quite fear-inducing as well, because if you all of a sudden have an electric shock down a leg, that is quite a different experience than just an annoying ache.
It can be much scarier.
Much scarier. Yeah. And we do know that from the literature. So people with neuropathic pain, they have higher anxiety levels, they have more depression, also in entrapment neuropathy. So it's important we understand, does somebody have neuropathic pain or not? And for that, as a clinician, we need to understand their history. We need to understand, do they have these neuropathic characteristics? So do they have tingling, numbness, a burning sensation, electric type shock sensations, cold pain? And we need to do a very careful neurological examination. And all this information taken together can help us make the decision whether somebody has neuropathic pain or not.
So what then are the best tools that physios can use, or who do we need to refer to and get on the treating team for people presenting with these neuropathic pains?
Yeah, I think physios are excellently placed actually to treat people with neuropathic pain. Especially, I say, you know, if we now think about spine-related leg pain, for example, especially if there is not a very strong neurological deficit. We can absolutely help people make sense of the condition. We can help them find strategies. How can they control the pain better themselves, etc. But of course, there is sometimes certain neuropathic conditions where we need input as well. So that can sometimes be pharmacological input. So that would be the GP or sometimes the neurologist. It depends a bit on the setting. And sometimes that might also be a surgical opinion. So some people need a surgery. So for example, if you think about radiculopathies with, for example, a foot drop or a severe neurological deficit, sometimes surgery is the right option for these patients as well. So I think I quite see it as working in concert in a way between the different teams when seeing patients with entrapment neuropathies.
So when we think about things like mechanosensitivity and neurodynamic testing, what's actually going on in the nerve when we're doing our sliders and gliders and doing our slump or our straight leg raise?
So when we move the nervous system with these tests, what we try to do is see how do these nerves relate to having more tension. I always say, it's actually quite similar to do a muscle length test, and we just see, can we provoke symptoms? So these are symptom provocation tests, but in a way specifically for the nervous system. And if nerves are, for example, a bit inflamed or irritated, even just on the outside of the nerve, they tend to react with more pain when we put tension on it. So that's kind of what we look at. When we then treat patients with these kind of interventions, so for example, we know neurodynamic treatments are quite good for people who have heightened nerve mechanosensitivity. There's a lot of speculated mechanisms, so we think it could potentially improve blood flow in the nerve, it could potentially have regenerative effects, so animal models show that it leads to quicker remyelination, less axon degeneration. For example, we have shown that in diabetic animal models, that if the rats train neurodynamics, they basically have less degeneration of the axons. In humans, our knowledge is a bit less clear. We have some studies that demonstrate that it can reduce the swelling inside the nerve, which is probably a correlate of inflammation. We have just recently done a study where we have tried to look, can it change the microstructure of the nerve, for example, myelination or axon degeneration? But we do not find that in a large cohort. We find some signs in patients with moderate kind of severity, where there is probably more structural damage. So there we seem to be able to induce recovery. So for example, show that after neurodynamic treatment, patients with carpal tunnel syndrome seem to have faster conduction velocity again. This is a sign of remyelination. So there might be these signals in humans, but a lot of it still remains a bit unclear, and a lot of our knowledge still does come from animal work.
What's the role of things like cortisone injections and other medical interventions for entrapment neuropathies?
So it is quite commonly used in a range of conditions. So Morton's neuroma, radicular pain, carpal tunnel syndrome, very commonly treated with steroid injection. The evidence in terms of effectiveness tells us they're effective in the short term, 3 months, but they're not better than placebo in the long term. Some studies tend to come out that also show in some conditions, now this is outside entrapment neuropathies, but for example lateral epicondylalgia, it might actually delay symptom improvement as well. And I think this is quite interesting because there's more and more research coming out that if we suppress inflammation, for example, in patients with spine-related leg pain who take early on anti-inflammatories, they seem to have a slower recovery. So sometimes actually suppressing inflammation might not be quite the right thing. And some of our research in Morton's neuroma suggests that a certain type of immune cell is also dysregulated, and that immune cell is actually associated with nerve-related pain. And it is an immune cell that is induced by glucocorticoids, so by steroids. So we are also wondering a bit, could it be that in some people, steroid injections, even though they might have that short-term benefit, in the long run might actually not be the thing? But we don't have the full evidence for it as yet. So at the moment, that remains a hypothesis biologically.
I'm guessing we probably can't predict who those people are at this moment.
That would be amazing. I mean, that is something that me and my team really try to find out. even just non-invasively showing which patients have inflammation inside their nerves and which patients have not. Because that is not so easy. We can obviously look at blood measures, but they are very variable in people, and we can't have a cutoff and say if you have whatever a CRP above that, then you have inflammation inside your nerve. That doesn't work. We are at the moment working on developing specialized MRI sequences that are specifically imaging the nerve microstructure, and we are seeing whether these could help us detect such neuroinflammatory changes in the nerve. Because you're absolutely right, I believe as well, if we could pick those people with inflammation in the nerve, it might well guide what kind of treatments might be better. And we do know that inflammation varies between people. Not everybody with an entrapment neuropathy will have a dominant inflammatory response, but others will have quite a strong one.
And generally, the theme I've picked up from your talks today is if we can be really clear with what's going on for each patient and really understand the mechanisms involved, then we can really try and steer them towards what we think is the right treatment.
Yes, and that is indeed at the moment where we are at with research. We know that most of the trials that we do in entrapment neuropathies, but often in other pain conditions as well, they have either no or moderate small effects. So we are not very good at treating, for example, entrapment neuropathies, physiotherapeutically as well, but also pharmacologically. So the question is really, is it just that our treatments are not good and we should just move on and find better treatments? Or is it a bit that we try to treat different patients the same way and that might just not work on average, but it might work in a certain group of patients? And this is very much where I think we should be moving. I do think we have treatment that are probably promising. They're promising from a neurobiological perspective. In a relatively dirty group of patients, they show small effects, which is probably promising. But could we improve these effects and this effectiveness by targeting it to the right patients? And I believe this is where in research we really should be moving more strongly in entrapment neuropathies.
And I think not just entrapment neuropathies, but pain in general.
Yes, absolutely. I mean, we have gained a lot more understanding about this massive heterogeneity in pain, and it almost seems slightly naive to think the one medication will do the trick for everyone. And equally, as a physio, I also think it's probably a bit naive to think that one intervention, say even neurodynamics, will do the trick for everything. I believe we have to become much more specific in a way.
Absolutely. Thank you so much for your time, Annina. It's been lovely talking.
Thanks for having me.